Good morning to all of you. I warmly welcome everyone for today's CPD program organized by Government Medical Officers Association and Society for Health Research and Innovation. The webinar link will be open to you until 10 a.m. and no late attendees will be entertained thereafter. Each attendee should attend till the end of webinar to obtain e-certificate for participation. You will be given CPD points which are strictly adhered to NC-CPD guidelines. But apart from CPD points, you will be given the e-certificate for participation. The link for applying certificate will be sent to the chat box at the end of session. Also, we kindly ask you to mute your microphones and switch off videos to avoid any interruption during the session. There will be connection issues and technical issues. And please stay with us. We will be back very soon. So now let me introduce our speaker today. Today, our resource person is Dr. Amila Walawwatta, who is a consultant cardiologist at District General Hospital, Shillong. So without further delay, I would like Dr. Amila Walawwatta to give his talk. Sir, session is over to you.
Right, very good morning to all of you. So basically my talk today will be on management of dyslipidemia. So here I'll be going with very simple basics so that you will find management of a patient with dyslipidemia easier. So let's start with a bit of basics. We know lipoproteins because of its pathogenic characteristics. But however, there are some utilities of lipoproteins. So what are those utilities for us? Because lipids are used as sources of energy. Also, lipids are deposited in tissues so that it helps us, maintain our body figure configurations. And also, lipoproteins are used for hormone production and also bile acid formation. There are some utilities of lipoproteins for us. However, we are worried about lipoproteins mostly because of its pathogenic characteristics. So let's start with the structure of lipoproteins. As you know, it has a lipid component and a protein component. So the lipid component consists of cholesterol or triglycerides as well as phospholipids. And the protein components is known as apolipoproteins. So these protein components are there in the lipoproteins so that the lipoproteins would bind to tissues. So these are there as ligands for cellular receptor binding. So there are different types of lipoproteins in the blood. Certain lipoproteins have high triglyceride components and are bigger in size and are less dense, whereas others have low triglyceride component and high cholesterol component and are more denser. So starting with the top, the chylomicrons they're bigger, high in triglyceride and low denser. As the list goes down, you see the density increases from chylomicrons to VLDL particles, then intermediate density or IDL particles, the LDL particles, the low density lipoproteins, and a lipoprotein A, which is also actually a subcategory of LDL cholesterol, and the density is highest in the HDL cholesterol. So these are different types of lipoproteins which exist in the blood. So how lipoproteins are produced, I will not go into details, but basically the chylomicrons are produced when lipids in food is degraded and absorbed to the blood. It comes as chylomicrons. So in the non-fasting age or after meals, you will find more triglyceride in the blood because of increased chylomicron levels. All the other cholesterols are produced by the liver. The lipoproteins are produced by the liver, including VLDL, then ILDL, LDL, and all that. As you go down in this list, you will find more cholesterol content and less triglyceride contents. in these lipoproteins. So those are a bit of basics about the structure of lipoproteins, the type of lipoproteins, and etc. So how do these lipoproteins become pathogenic? For it to be pathogenic, those lipoproteins are smaller in size, less than 70 nanometers, and have these ApoB, the protein component in those lipoproteins. Those type of things could uh, attach to the endothelial layer and cross the endothelial barrier, especially when there is endothelial dysfunction, which is often happens in patients with atherosclerotic risk factors like hypertension, diabetes. So these particles could cross the endothelial barrier, enter the tissues, enter the vessel wall, and could interact with extracellular structures such as proteoglycans, leading to formation of cholesterol plaques. So this is how this becomes pathogenic, especially those smaller particle cholesterols, which has these properties, belongs to the LDL category. So those are the cholesterol which will cross the endothelium and then would lead to the formation of cholesterol atherosclerotic plaques. So let's talk a bit about lipid profile. Now, in lipid profile, we are mostly worried about the total cholesterol level and more importantly, about the LDL cholesterol level. But do we actually directly measure the LDL cholesterol level? The answer is no. In our lipid profile, the assay estimates the total cholesterol level, the triglyceride level, and only the HDL cholesterol level. So we calculate the LDL cholesterol level by a mathematical formula. So blood has the triglyceride level. If we divide by, the triglycerides are mostly in the VLDL particles. So if we divide the total triglyceride level by 5, we could roughly estimate the cholesterol component in the VLDL particles. Right? So if you know the triglyceride level, say 150, if you divide by 5, you get a value of 30. So that means there is cholesterol levels of 30 in VLDL particles that you can estimate from the triglyceride level. HDL we directly measure. The total cholesterol we measure. So the gap is the LDL cholesterol level. So in your reports, the LDL cholesterol level is not directly measured. So if someone gives you the total cholesterol level, triglyceride level, and the HDL level, you should be able to calculate the LDL cholesterol level. So do we need to wait fasting to obtain a lipid profile? Well, still traditionally we do that. We take about 10 to 12 hour fasting for lipid profile, but it's not essential. But what you need to understand is that if you are non-fasting, that means if you're after a meal, the component of triglycerides, the level of triglycerides is tend to be higher because there will be more chylomicron particles after a meal. But what we are worried mostly is about the LDL cholesterol level. So even if you take a non-fasting cholesterol level, that's fine for your management purpose. But if the triglyceride level comes very high, then that may be due to this meal-related hyperchylomicronemia. So you may need to do a fasting one to see whether what you need to do about the very high triglyceride level if it comes down that level. But otherwise, even for an ACS patient, you should be able to take just a non-random, non-fasting lipid profile, which is good enough to guide your therapy. So let's move on to the management. So in our management, we have few questions to answer. Do we need to treat the patient? Or we need to treat them immediately, or is there a place for initial lifestyle modification before we embark on medical therapy or pharmacotherapy? And what are our cutoff levels beyond which we would intervene? Those are the questions that we need to answer. So how do we set about things? So now the guidelines suggest to decide on management of a particular patient, you need to assess the cardiovascular risk of that patient. What is this cardiovascular risk? This is a 10-year estimate, the estimate of a first fatal cardiovascular event over a period of 10 years. That means what is the probability of someone dying of a cardiovascular event within the next 10 years. So based on this risk estimate, we are going to see how aggressive we are going to go on management of that patient's lipids. For that, there are different kinds of score systems, different kind of score systems. So this particular score system, which I highlight here, is the one which is often used. So here, if you go on the internet, or if you find a certain graphs, you should be able to quantify a person's 10-year cardiovascular risk. For this, we use the age of the patient, the gender of the patient, whether he's or she is a smoker or a non-smoker, and so what's the blood pressure level and what's the total cholesterol level. So based on these factors, we can estimate the 10-year cardiovascular risk. You might question me, why isn't there diabetes in that list? Why isn't there CKD in that list? All that. But if you have any one of those kind of risk factors like diabetes, you don't need to use this score system because you automatically fall into higher risk or very high risk categories. So those things I'll elaborate as we go on. But for those without diabetes, without CKD, and without established cardiovascular disease like stroke or ischemic heart disease or peripheral vascular disease, for those patients without those kind of obvious high risk conditions, you use this formula. But if you have obvious high risk conditions, you can obviously straight away call them without this model. You can just say call them high risk or very high risk. So what are these high risk and very high risk categories? So if your 10-year cardiovascular risk is more than 10%, you fall in the very high risk category. If the risk is between 5 to 10%, you fall in the high risk category. If it is 1 to 5%, it's the moderate risk category. And if it is less than 1%, it is the low risk category. So the formula will help us to decide what level of risk does our patient belongs to. So based on that, we could decide the management. So I told you before already that if there are high risk conditions, you don't need to apply this risk score. So these are some of the charts. Like you can just on the internet, you can enter the risk factors and calculate on apps, or you can use one of these charts. So if you look at this chart, you see you have to decide whether the patient is a male or a female, whether it's a smoker or a non-smoker, what is the age of the patient on this bar. Then you need to find the blood pressure level and the total cholesterol level. Then for each patient, it will tell a 10-year cardiovascular risk. So you can use one of these charts, but you can't. It's more easy for you to use an app, or you can just go to the internet, enter the risk, just type score system, enter the risk factors, and then it will automatically calculate the 10-year cardiovascular risk. But for those with established atherosclerotic disease, say someone had a stroke or a MI or stable angina or has intermittent claudication suggestive of peripheral vascular disease, then you don't need to apply this score system. They're obviously it's secondary prevention, and they are obviously very high risk category of more than 10% cardiovascular risk. Or also, if your patient is diabetic, they fall in high or very high risk category. Sometimes moderate risk categories as well. For example, if your patient has diabetes with target organ damage, it's a very high risk category. If your patient has diabetes over 20 years duration, again, very high risk category. If your patient has no target organ damage and has diabetes for 10 to 20 years, then it's a high risk category. Less than 10 years, no target organ damage, it falls in moderate risk category. So based on that, if you have diabetes, you can just estimate the cardiovascular risk without using those risk categorization models. If your patient has CKD stage 4 or 5, again, very high risk category. If you have familial hypercholesteremia, fall in high risk category. So those are some of the other things where you don't need to use those apps or calculations. You can straight away put them in risk categories. So when do we start lipid lowering therapies? So what are our cutoff points? And are we going to straight away put them on medication, or are we going to wait with 3 months of lifestyle modification? So let's start with the cutoffs. So if your patient falls in very high risk categories, so as you can see here, it's a very high risk category with a 10-year cardiovascular risk of more than 10%. Your LDL cholesterol target, that is the most important thing. The LDL cholesterol target should be less than 55. So if the LDL cholesterol level in your patient is more than 55 and he or she has already established cardiovascular disease, say stroke, MI or PVD or something like that, or if you use the model and the model tells you that the risk is more than 10%, then your goal is to get LDL cholesterol level less than 55. It's a very aggressive type of lipid lowering therapies. So that's your target. So if the value comes above 55, you start treating them. Whereas if your risk is 5 to 10%, that is high risk category, the LDL cutoff to treatment would be 70. If you fall in the moderate risk category, where the Denier risk is 1 to 5%, your cutoff is 100. If your risk is less than 1% and you fall in the low risk category, the LDL cholesterol target is 160. So fairly aggressive lipid lowering therapies. So these are our cutoffs. So beyond this cutoff, we are going to do something and bring the cholesterol down. So then the next question, are we straight away going to put them on medication, or are we going to just try some 3 months of lifestyle modification? So the answer is this. So if your patient is in secondary prevention, that means your patient is a very high risk patient, already got established atherosclerotic disease, just straight away put them on medication along with the lifestyle modifications, both at the same time. So cutoff is 55 level of LDL cholesterol. So that's your cutoff. So above that, secondary prevention, that means established disease, you straight away start them on medications, right? Whereas in primary prevention, for example, if your patient has a very high risk category, that means over 10 years, but it is not, he doesn't have the established cardiovascular disease. But when you use these risk stratification models, it tells you this risk is more than 10. So that is primary prevention, but in a very high risk patients. Just because the cholesterol level is just over 55, you don't need to straight away put them on medication, but you could try 3 months of lifestyle modification. However, if the cholesterol level is a bit way off range, for example, your target in that patient is 55, the level is over 70, you don't wait, you straight away start. But if it's just over 55, say in between 55 to 70, in between the next two categories, you could try 3 months of lifestyle modification to see without medication whether you can bring it down. But if it's gone beyond the next step, above 70, when your target is 55, you don't just wait with lifestyle modification, you start lifestyle modification plus medication at the same time. So both at once. So example, if you take another instance where you can get a moderate risk patient, your target is 100, and you get a cholesterol level of 110, you may try a bit of lifestyle modification for 3 months and see whether you can bring it to less than 100. But if the target, your target is 100, the cholesterol level comes as 130, 140, way off range and gone beyond the next step, then you have to start medication plus a lifestyle modification at the same time. So it depends on whether you are just above your target, just above your target rate, you could just wait for 3 months of lifestyle. But if it's gone 2 steps beyond and beyond the next category, then you have to start lifestyle modification as well as medication at the same time. Yeah. So those are our targets. So high risk categories target is 55. Very high risk categories target is 55 LDL cholesterol milligrams per deciliter. High risk 70, moderate risk 100, and low risk 160. So those are our targets. So we talk of different kind of risk factor to quantify the 10-year cardiovascular risk, but though that's basically a simplification. There are certain risk factors which is not put in those apps or models, risk score models, but these also fine tune the 10-year cardiovascular risk. For example, social deprivation, stress level, psychologically, the physical inactivity, obesity, the family history, and chronic inflammatory condition like rheumatoid arthritis. So those conditions also do elevate the 10-year cardiovascular risk in certain degrees, but we can't put every risk factor. You want to make a simplified quantification of the 10-year risk. So they've used the most important one in quantifying the 10-year cardiovascular risk. So when you go on medications, what are your arms of therapy? The steps are like this. You start with a statin. Your goal is LDL cholesterol level. So we will talk about triglycerides later. The goal is basically the most pathogenic, more atherogenic, the lipoprotein in the blood is LDL cholesterol. So your aim is to reduce it as much as possible. You start with a statin. You can start with a moderate dose, but if it's an ACS patient, you may start with a high dose. And if your target is not reached, you optimize to the highest possible statin dose. That's the next step. And if even with that, if your cholesterol level is not reached, then you add on ezetimibe as a combination therapy to lower the LDL cholesterol to hit your target. There are some high-end therapies which are not freely available in our countries, which can be used as third line, like the monoclonal antibodies. They're very expensive and not really available in our country, like PCSK9 inhibitors. Those are very often not used. So we basically manage most with statins, going with high-dose statins if required, and add ezetimibe if our targets are not reached. So I don't want to fine-tune into lipoprotein A measurements. Those are some of the things which can be further restratified the risk from lipoproteins. So what are the lifestyle modifications we want to talk of? Obviously, we want to lower the cardiovascular risk. So cessation of smoking is one of the things we can do. And we could optimize our diet for that. Basically, we need to reduce the carbohydrate levels, number one. Number two, we need to reduce the saturated food intake. So we need to have more fiber in our diet, essential amount of proteins, but cut down on the saturated fats and cut down on the carbohydrate level and the saturated fats. So aiming at obtaining an optimum BMI level in between 20 to 25. That's our target. So physical exercise is also an essential component, at least half an hour to 1 hour for brisk walk per day to burn your calories and to achieve optimum BMI level and to control the blood pressures. Those are important. So very often people ask about, whether to use coconut oils. So basically coconut oil is a saturated fat. So but it's what we have, but what is available to us. So using is fine, provided that the usage is in moderate. But theoretically speaking, it's a saturated fat and less favorable as compared to polyunsaturated fats. So, but mostly our diets burn us with loads of calories. That is where we get into trouble with increases of diabetes and issues. So it's a trivial thing. I don't think that we need to focus much on the oil use, as long as we used in limited amounts. But preferably, if we have the options of going for polyunsaturated fats, that's better. So that's where it stands. So let's move on to how do we do the muscle enzyme level evaluation, because we know statins can cause myositis in certain patients. So how do we set about in screening for that? So basically we do a baseline creatine kinase estimation, because if the baseline is elevated, that can complicate our management later on when we found we don't know whether it's a pre-existing one or not. So before you start on therapy, you need to know the C creatine kinase level. And after starting therapies, we don't often recheck. But if the patient develops any kind of symptoms like myalgia, then we need to go back and check the creatine kinase level and compare with the pre-treatment level and decide what we're going to do. So if your creatine kinase level becomes very high, it goes more than 4 times the upper limit of normal, or if your patients get cross rhabdomyolysis, then you need to immediately stop treatment. So if the CPK level is very high, like more than 4 times, we stop the statin for about 6 weeks, and we repeat the CK level to make sure that it comes down to normal range, and then we could try with a different statin at a lower dose. Sometimes it may even be once a weekly dose sometimes, so that we under monitoring to see whether we could put on some kind of a lipid lowering therapy which is tolerable to the patient. But even failing that, the next option would be to go on to ezetimibe once the CK is normal, and if we fail to try with another statin. If your CK goes up a bit, say less than 4 times the upper limit normal, you stop the statin for a short duration, maybe 2 weeks or maybe 4 weeks, and you repeat the CK level. If the CK levels remains high, then you obviously will have to look for a different dose for the CK elevation apart from statin use. But if the CK normalized, then you assume that it's due to the CK, the statin-induced myositis, then you would again try a different statin at a lower dose, and failing which, again, the option would be to go on to ezetimibe. So how do we go about the liver enzyme assay? So again, before treatment, we need to know the basic baseline AST/ALT levels. And if the AST level is high, you have to look for what is the cause for that. But if AST/ALT is normal, you start on statin, then about a couple of months, you repeat the AST/ALT level. If it's go up a little bit, say up to 3 times the upper limit of normal, you could still continue with the same therapy, and you recheck the liver enzyme levels. But if the liver enzyme levels go very high, off range, say more than 3 times upper limit of normal, then you stop the statin and then recheck the liver enzymes in about 4 to 6 weeks time, and make sure that it has returned to normal, which indicates some kind of a connection with the statin use. So you look for any other alternative therapies to lower the cholesterol. But if the liver enzyme remains high, you have to look for other causes, maybe some hepatitis screening, etc. So with regard to triglycerides, basically triglyceride is not atherogenic as LDL cholesterol. So we're not going to go aggressive in lowering triglyceride levels. So if your triglyceride is slightly high, say the reference range is 150, and your cholesterol triglyceride comes as 250 or something, then you don't do aggressively treat it with a fenofibrate, because it doesn't elevate the cardiovascular risk much, simply because of triglyceride level. There you look at the LDL cholesterol level or the non-HDL cholesterol level. The non-HDL cholesterol is total minus HDL cholesterol level, because triglycerides also, the triglyceride, when the level is high, there is some cholesterol inside those VLDL particles. So we said about 1/5 of, if you divide by the triglyceride by 5, you can quantify the level of cholesterol inside those VLDL particles. And so what we do in those scenarios is that your LDL is little high. So LDL comes as 130 or 140. Your triglyceride is 250. Your focus is not lowering triglyceride. Your focus is lowering the LDL cholesterol level. So that is the way to reduce cardiovascular risk in that patient. So you can use the LDL cholesterol level is to treat the patient, Or else if the LDL cholesterol is only slightly high, triglyceride say comes to 5300, we use the non-HDL cholesterol level. So in non-HDL cholesterol level, the target cutoffs to treat is very simple to remember. We know our LDL cholesterol targets for different patients. We know 55, 70, 100, 160. We already have talked about it. To get the corresponding non-HDL cholesterol target is, you add 30 for that. So example, you have a patient with a moderate cardiovascular risk of 1 to 5%. Your LDL cholesterol target for that patient is 100. Your non-HDL target, the corresponding non-HDL cholesterol target would be 30 plus that. So that's 100. If the target is 100, the non-HDL target is 130. So when the LDL is, bit borderline to decide on treatment, triglycerides is moderately elevated, you use non-HDL cholesterol targets to guide your therapy. So we are not going to just treat moderately elevated triglyceride levels by a phenofibrate. So our basic aim would be to reduce the total cardiovascular risk in that patient. So it's may sound a little complicated, but it's very simple. When triglyceride level goes up, if it goes up very high, obviously you have to treat that for a different reason. For example, triglyceride comes at 500. Then you have risk of central retinal vein occlusion, you have risk of pancreatitis and those kind of complications because of very high triglyceride. You treat with phenofibrate, that's different. But if your triglyceride is moderately elevated, your focus is not on triglyceride. Your focus is on the LDL cholesterol level. But when the LDL cholesterol level is borderline only mildly elevated, you have a dilemma whether to treat or not. You calculate in that kind of a patient the non-HDL cholesterol level. That is total minus HDL. Because when the triglyceride level is moderate high, that also has a bit of cholesterol. That also you want to take into the overall picture. So you go for non-HDL cholesterol level, take 30 plus the LDL target and check where the non-HDL cholesterol level stands, and you decide whether to give a statin or not. If your statin doesn't bring, if after that you start a statin, you check again the triglyceride level. If the triglyceride level is still moderately elevated, you could add some fish oils for those kind of patients to lower the triglyceride levels a bit further. Phenofibrates we usually keep reserved to treat very high triglyceride levels. That's also with a different aim, not to lower the cardiovascular risk, but prevent certain other complications which is related to high triglyceride levels. So with regard to women, there are a few issues because statins are not used in pregnancy as well as in breastfeeding. In pregnancy, you can have acute dysplasia and certain complications because of statins use. So in childbearing age patients who wishes to get pregnant, so no patients who are pregnant, we tend not to use statins. However, when the risk is higher, when the childbearing period is over, we want to put them on statin if the lifestyle modifications doesn't bring in the necessary risk lowering that we intended. So once we start medications on a patient, how often do we test them? We test them in about after 2 months of treatment or whether we've achieved our targets. When we increase the dose also in about 2 months, we can check. But on a patient who's well controlled on the same dose, we don't need to repeat the cholesterol at frequent interval. Maybe we could do it at about annually. So with regard to secondary causes of dyslipidemia, there are a few causes like hypothyroidism, nephrotic syndrome, primary biliary cirrhosis, etc. But the most often forgotten one is hypothyroidism. So if your patient has dyslipidemia, it's reasonable to check the thyroid function test and to see whether the patient has hypothyroidism as a cause for dyslipidemia. So in that kind of a patient, your patient is hypothyroid, your lipid levels are elevated, your triglyceride, total LDL, all cholesterol components can go up. So in those patients, you could treat the hypothyroidism and check the lipid profile in about 2 to 3 months and then decide whether the patient needs treatment. However, if the patient is hypothyroid, has elevated lipid plus has already got established cardiovascular disease, that means patient has angina or something, or a stroke or peripheral vascular disease, you don't wait for the thyroxine to bring in cholesterol. You straightaway start medication because that falls under secondary prevention category. But if it's a patient who doesn't have established cardiovascular disease, you could treat the hypothyroidism and see in about 2 to 3 months whether you can bring down the lipoproteins to optimal levels. So some of the drug interactions, and I don't want to go deep into that. So that will basically conclude my presentation, a simplified version and update on management of dyslipidemia.
Thank you very much, sir. Thank you very much, sir. Thank you for excellent and very descriptive talk regarding management of dyslipidemia. So next, we will move on to the Q&A session. Sir, we have got a few questions. I will go through that. First question, level of triglyceride that should be considered as in a non-fasting lipid profile, as very high in a non-fasting lipid profile. Hello?
Yeah. So if you're non-fasting lipid profile, I told you already that non-fasting the lipid, the triglyceride component is high because of increased chylomicrons. So if your triglyceride say comes as over 500, then the triglyceride component is very high. But in a non-fasting state, we don't know whether it's truly high or whether it's due to this food, meal-related, the high elevated chylomicron level, which causes this much high triglycerides. In that kind of a situation, you need to go back and do a fasting lipid profile and to see where the true triglyceride level in the fasting state stands. So if you're non-fasting triglycerides comes at 300 or something like that, I wouldn't be extra worried. But if it comes as 500, then I would like to know whether it's due to the meal-related chylomicron levels. The patient truly has persistent hypertriglyceridemia. So I'll go by that level.
Next question. In a newly diagnosed hypertensive patient, should we start statins depending on his high or very high Denier cardiovascular risk, even if the patient has normal lipid profile?
Yes, what do you mean by normal? I've already told you where the patient belongs. So if your patient has more than 20 years of diabetes, that patient has a very high risk category, that more than 10%, 10% Denier cardiovascular risk. So in that situation, your target is 55 LDL cholesterol. So if your patient, slightly off that, say patient has 65 LDL cholesterol, I would try a bit of lifestyle modification to see whether I can get to that 55 target. But if the patient, have, over 70 milligrams of the LDL cholesterol and more than 10-year cardiovascular risk, which we have already told, then I would put on statin plus lifestyle modification. So it depends on where the patient stands. If it's diabetes of less than 10 years, 7 years, 6 years, the risk is moderate without target organ damage. So in that patient, the risk is moderate. The target is about 100 LDL cholesterol. So if it's diabetes 10 to 20 years, the risk is high. That is 5 to 10%. So the other target is 70 LDL cholesterol. It depends on what our target for individual patient is and whether we are just above that target or well off that target. If you're well off that target, we have given 4 strata, 55, 70, 100, 116 for different risk categories. So if if your patient is off target and 2 steps away from that target, then you start immediately medication. But if it's just above that, you could just try a bit of lifestyle modification and see whether that works over the next 3 months. But if it's secondary prevention, patient has already ischemic heart disease with diabetes or whatever, just put them on statin plus lifestyle modification at the same time.
Next question, sir. coconut oil known to increase the LDL 10 milligram per deciliter and HDL in 5 to 8 milligram per deciliter. Since LDL is robust, so CV cardiovascular risk factor, what is your recommendation on diet with coconut oil?
Yeah, well, again, the international guidelines are very clear about that, saying that the polyunsaturated fats, like what we get in olive oil or the proper standard olive oil or the vegetable oils, which are made as per the international proper standards. The polyunsaturated variety is better than the coconut oil, which is the saturated fats. But given that there is no hard meta-analysis level evidence to say that this is going to grossly elevate the cardiovascular risk, but there are theoretical possibilities. So in that sense, while the polyunsaturated fat would be the ideal way to go, usage of coconut oil in moderate quantities could be accepted. In limited quantities could be accepted. The one important thing about the coconut oil is, although it's a saturated fat, it's the medium chain saturated fats, and we use a lot of heating in our cooking, so it doesn't produce trans fatty acids, which are known to be carcinogenic, like in palm oil. So it's relatively, there are some good properties about coconut oil compared to palm oil. It doesn't produce trans fatty acids. So with our food practice, which involve a lot of heating and frying. So in that way, there are some favorable things, but again, it's a saturated fat. So we should use in the limited quantities as much as possible. But theoretically speaking, and if it's available, the polyunsaturated fats are better than the saturated fats like coconut oil.
Next question, sir. Is there any good evidence of cardiovascular risk improvement with triglyceride control below 200?
Again, just because you put down the triglyceride level, it's not going to reduce the cardiovascular risk. What your focus is, how much is the LDL cholesterol level and how much it has been brought down, or the non-HDL cholesterol level, total minus HDL cholesterol is what we know as non-HDL cholesterol level. How much, because we know the targets. Now we talk to 55, 70, 100, 160 for LDL cholesterol. The same strata, you can just add 30 for each category. You can get your non-HDL cholesterol target. For example, you have a moderate cardiovascular risk patient. That's the 10-year risk is 1 to 5%. What's your LDL target? That is 100. So your non-HDL target is 130, just add 30. And in a patient with moderate high triglyceride level, you check that non-HDL cholesterol value, total minus HDL, and you use that to start treatment with a statin, not focus on the triglyceride level. That is what is going to lower your cardiovascular risk. You may add a bit of fish oil for that patient if the triglyceride is slightly highly elevated and your statin hasn't produced your triglyceride to the desired rate. You may add a fish oil. But fenofibrate we will not use unless the triglyceride level is very high. Because one thing is, it's not going to lower the cardiovascular risk. Number two, your combination of statin and a fibrate is not without risk. There's a high risk of myositis complications.
Next question, sir. What are the instances we can use lifestyle modifications and diet only to control hypertriglyceridemia and hypercholesterolemia?
Yeah, we could obviously, any patient with the dyslipidemia should use lifestyle modification. But as I already told, if you're just about your target range, so your target for a patient LDL 70, just above that, don't rush into start medication, just try a bit of lifestyle. But if it's well away from target, then you need to start lifestyle plus pharmacotherapy.
Next question. Next question, sir. What is the highest dose of statin before adding the combination therapy? Aesthetic.
Sorry, I didn't get it. What is the?
What is the highest dose of statin before adding ezetimibe?
You can go on to 40. I tend to go above 40. Then I need a statin. You can go with a statin to 80 milligrams of atorvastatin or so, but tend to just I most often stop at about 40 milligrams of atorvastatin or 20 milligrams of rosuvastatin, and then add ezetimibe.
Next question, sir. In a diabetic patient with normal cholesterol level, should we start a statin to reduce cardiovascular risk?
Sorry, I didn't get it.
In a diabetic patient with normal cholesterol level, should we start a statin to reduce cardiovascular risk?
Yeah, again, what you mean by normal is different. We have been talking about the same thing over and over again. I think in a patient, diabetes over 20 years, LDL should be below 55. 10 to 20 years, in a diabetes with target organ damage, irrespective of diabetes duration, your LDL target is 55. In a diabetes without target organ damage, if the diabetes is more than 20 years, target is again 55. The diabetes is 10 to 20 years, risk is high, then the target is 70. So diabetes less than 10 years, no target organ damage, the target is 100. So it depends on which risk category patient belongs. So there's nothing called normal cholesterol. It depends on what risk for that patient. We go very aggressively. We go to 55 LDL cholesterol, which were previously these kind of targets were not there about 4 or 5 years ago, but now the targets are different.
Next question, sir. What is the drug that causes minimal gastritis?
Sorry?
What is the drug that causes minimal gastritis?
The question is not very clear, that particular one.
Okay. The next question, sir. What is the management of dyslipidemia in hypothyroidism patient?
Yeah. If your patient has hypothyroidism and dyslipidemia, if the patient already has got some kind of a cardiovascular disease, say it's got a stroke or MI, you start with a statin. But if the patient doesn't have established cardiovascular disease, patient has hypothyroidism and dyslipidemia, you first treat the hypothyroidism. Check the lipid profile about 2 to 3 months. Once the thyroid is, the patient is euthyroid. Then if the lipid has not improved to the desired range, you can consider treatment. But if the lipids have brought down to the desired range, we just treat the hypothyroidism.
Next question, sir. How we can reduce the dose of statins when target level is achieved?
Extremely good question. Very often we see this kind of a practice where the patient is put on a statin, the target levels are reached, and the patient comes off medication, which is inappropriate. I mean, basically, you want to hit that target and to maintain that target. For example, if someone is a diabetic patient is on a sugar lowering therapy and the sugar isn't, comes down to normal for optimal range, you don't stop the diabetic medications because the patient again will get hyperglycemia. The same thing. So if you're on a target and you hit the target, you maintain the target. So example, if your patient is, your cholesterol target is 70, LDL cholesterol target is 70. The cholesterol levels comes out at 35 LDL. Then you may reduce a bit because it is gone well below your target range. But if you hit the target range, your target is 70, your cholesterol level is LDL cholesterol level is 65, you just maintain the same dose of statin. So you hit the target and you maintain the target. If you overhit it, then you can reduce. But very often we get it target and you should just continue with the statin. You shouldn't stop it. But there are situations where someone has dyslipidemia and is the body weight is about 120 kilos. That patient has done a lot of lifestyle modification. Now the weight is reduced to 80 kilos from 120. So now you find the LDL cholesterol is dropping too much. with your statin, you may reduce the dose a bit and to see whether you could tail it off, because the lifestyle modification had brought major changes in patients' body habits. So there you can see whether you can tail it off. But very often we will find their patient is at the target and you just maintain it. That should be the way in most patients.
There's another question, sir. If we start statin treatment, do we have to continue it lifelong? Can we stop treatment after LDL level come to normal?
No, you shouldn't stop it. You should continue. If it comes down way below the our target, you can reduce it. Yes. And you can even take it off, say, if the patient's, lifestyle modification is so good, the weight is reduced so much, and you can stop it. But even if you stop it, you should make sure that you repeat the lipid profile in 2 to 3 months and make sure it's not going to shoot up again. But most often, our practice is, just continue with the statin and keep it and hit the target and maintain the target. So you shouldn't come off statin unless you have robust evidence and confidence to say that once you've taken off the statin, the patient will maintain your ideal LDL target with whatever the lifestyle modification, which has worked so effectively. The weight has come down so much, and you're confident that you taking off the statin will not prevent the shooting of the cholesterol level. You may take it off, but again, should need to be done under caution and need to be followed up to make sure that the cholesterol level doesn't shoot back, which doesn't happen very often. Very often the patient is taken off statin, the cholesterol level goes back, and over a few years down the line, the patient may get the atherosclerotic complications, which is not what we should be doing. We should hit the target and maintain the target. Under very selective conditions, when there's grounds to think using just common sense, okay, the weight has come down so much. I think I could take off, the LDL is coming down too much. I think I should be able to tail it off and may make sure that it doesn't go up. In selective conditions, we may do.
If a breastfeeding mother having high CV risk, what are the treatment?
Breastfeeding period, again, it's a period of, not for a very prolonged time. It's basically about 12 months of breastfeeding. You need to judge, make a judgment on that patient. So with breastfeeding, we tend not to prescribe the statins. So if your patient has essential requirement to be on a statin, then you need to think of giving an artificial formula and putting the patient on statin. But most of the time, our practice would be to let them feed the baby and take off statin for that limited period of time. And once that is over, to put back the patient on statin. That's a normal practice. But again, it depends on the individual risk of the patient. The patient has MI, you need to be giving the statin, and you are desperate to put the patient because of aggressive cardiovascular disease. You need to wean the baby off breastfeeding and then to put down statin. But most of our patients, most of practice, these patients are at a very low cardiovascular risk. Ladies, premenopausal, they're menstruating, their cardiovascular risk is pretty low. So most of the situation, we should be able to let the patient have the breastfeeding, just manage the dyslipidemia with whatever the lifestyle modification which is available. And then when that period is over, to see whether the patient needs pharmacotherapy after the breastfeeding is over.
Is there a difference between statin, atorvastatin, simvastatin, and rosuvastatin?
Well, generally, rosuvastatin is more potent. For example, it's twice, say, 40 milligrams of atova and 20 milligrams of rosuva, just tally. So apart from that, most of the time we tend to use either atorvastatin or rosuvastatin. There is no big difference as such. And pravastatin, there are different statins as well.
What is familial cholesterolemia and its management?
Familial cholesterolemia, again, management depends on what cholesterol level elevation. So most of the time, patient will require pharmacotherapy essentially, even if the patient is young, because the cholesterol is very high, the LDL is more than 190. So even if the patient is 18 years, 20 years, you should start treatment because the levels are so high. You very often need to go on to high statin doses. You very often need to add on ezetimibe to get into the target range. and to manage that patient with more aggressive lines.
In initial cardiovascular assessment, is angiogram or CTO angiogram a must?
No, it's not. If the patient doesn't have grounds to indicate that there is cardiovascular disease, you don't need uh, angiogram is essentially not required unless the patient has evidence to justify that. CT angio, the threshold is a little bit lower, but then again, it's not recommended to routinely screen everybody. It's when you have a judgment, for example, patient has a group of atherosclerotic risk factors, there are some vague symptoms like shortness of breath or something, you're worried, or maybe because of excess family history. It's an optional test which you could pursue with. Uh, but if you have symptoms, yes, because exercise ECG will you may not be able to pick up with good sensitivity. So if there are doubt about atherosclerotic disease or high risk profile, you may go get a screening or CT for angiogram.
Rosuvastatin is the preferred statin with patients with HIV due to minimal interactions with ART. Any other alternatives?
That is something probably I need to refer. I'm not entirely sure about the interaction with antiretroviral therapy. I'm not confident to answer that question. We need to refer back that.
LDL more than 400. What is better, atorvastatin 40 milligram or fenofibrates?
So LDL more than 400.
Yes, sir.
LDL, the fenofibrate will not work. LDL high, you need to go for a statin. Fenofibrate will only work for triglycerides. Statin is the one which goes for LDL.
That's all, sir. Thank you very much.
Thank you.
Thank you very much again. I thank all the participants who participated today's webinar, and also we kindly ask you to send your feedbacks on behalf of webinars in future. Thank you very much. Have a nice day.